My name is Dacre Robinson, and I am the chair of the University of Pennsylvania Center for AIDS Research Community Advisory Board. And our job is to be the community voice when it comes to HIV research. So what we do, we listen to different researchers. If they want to do research in the community, they ask us questions about how can they get people to be a part of research. We look at their research protocols and things of that nature. So if you're interested in being a part of our CAB, Amy Honorado, who is our coordinator, who will put her information in the chat, will please, you can contact her. At this time, I'm getting ready to introduce the man of the hour. Dr. William R. Short is an associate professor of medicine with a secondary appointment in obstetrics and gynecology at the Perelman School of Medicine, University of Pennsylvania. He graduated with his Doctor of Medicine degree from Hahnemann University. Subsequently, he completed an internship, residency, and chief residency in internal medicine, followed by an infectious disease fellowship at the MCP Hahnemann University. Locally, Dr. Short serves as the Associate Director of the Penn HIV Clinical Trials Unit, ACTU, and the co-director of the Clinical Core of Penn Center for AIDS Research, which is the CFAR. Without further ado, I introduce you again to Dr. William Short.
Thank you so much for that kind introduction. I'm going to share my screen before I start talking. So thank you everyone for spending time today. It worked a few, there we go. Let's turn it on. If somebody can just give me a thumbs up, it takes a minute to adjust, but then we're good. Yeah, perfect. All right, so thanks again for spending your afternoon with me in lunch hour. I want to begin by saying I don't want this to be a lecture, so I know there's a lot of screens with names on it, but I really encourage you to stop and talk. I've put in here really a wealth of information about your labs, and we were talking before we went live. This is what my patients ask me and what I discuss with them. That doesn't mean that this is everything, but it's really comprehensive. So if you don't see something in here, feel free to ask. I think we have plenty of time. And like I say, please, please, please make this interactive. I start out with this fun picture because while we all go to providers and, you know, we have regular office visits, myself included, a big component of that is lab work, right? We all get tired of what do they do with all this blood work? And, you know, I think since the age, you know, we all have our cell phones and we go through and look at our labs. And what you see is there's all these numbers and people get very confused by the numbers. And they have these little wiggly lines now that say green if it's okay. And if it falls out, then it's yellow and maybe red. And they really give you no sort of description or understanding of what those mean. So my hope is to be able to share that with you so you can have a better understanding. And really when you walk in to see a provider, have that provider, one, not look at their computer the whole time, actually look at you and talk and be able to answer your questions. All right. So with that, let's get started. This is what I plan to cover. So what I thought would be helpful is one, to talk about Cd4 counts. There's really a lot of things to talk about there. You know, I feel like that when patients come in, they say to me, what are my counts? And there are 2 counts. So I want to make sure you walk away, you know, none of the other stuff yet. You must know and understand Cd4 counts and viral loads. A lot about blood sugar, and I'll explain why. And I'm going to talk in there about diabetes, how I monitor your kidney function, your liver function, your lipids, your cholesterol. And then lastly, I put in, and I was very strategic in how I did this. I didn't want to start talking about sex initially, because once we do that, the rest of the conversation's gone. So I want to get the other basic stuff in, and then we could talk all about sex for the remainder of the hour. All right, so let's start with a Cd4 count. Very basic, very fundamental. What's interesting about Cd4 counts is they are very, very complicated. Right? So you get this single number. They're very complicated. One thing to know is that if I check a Cd4 count right now, and it is March 11th at 12 o'clock, if I recheck your Cd4 count in an hour after that, tomorrow morning, it's going to be all over the place. That's why I'm saying they're very, very, very dynamic. Look at this range here. This is what we consider normal, 560 to 1,840. That's a huge range. And I'm going to come back to this because I always get asked what is normal, and I'll explain that in a second. You know, they have different variations, which I just described. One thing that people don't talk about is what is considered abnormal. So if you walk in and you've been living at a Cd4 count, you're on treatment, you have a Cd4 count of 500, all of a sudden you go in one day and you're like, oh my God, my Cd4 count dipped to 390. I'm losing T cells. I get calls and I say, nope, don't worry about it. Why? Because you really need a change of 30%. And I'll explain that in a second. Just know that sometimes you can go up and down on either side, and it really is not what we consider significant. Really, we use Cd4 counts for one thing. I know that sounds crazy. It's really to stage where you are at diagnosis. And then we want to make sure you get above a certain level. So if your Cd4 counts 100 at diagnosis, that means it's low. And then we get you up to 300, 400. After that, we get that number where we never act on anything other than that at the beginning. And it helps us tell us when you're at risk for different infections. This is a typical result that comes back in Penn. So most people look at that and have no idea because everything says CD something or another. There's percentage, there's abs, there's lymph, there's counts, it's ratios, and people get very, very confused. So one thing I want to show you before I move on is when you see this complicated mess, and that's what it is, you really want to focus on two numbers. So one is CD4, so you can get rid of CD3 and CD8. And they actually recommend that we not even do this. Unfortunately, sometimes with lab panels, we're kind of stuck with what we order. But you're really looking at CD4 and you're looking at two numbers, the absolute count and the percentage. And I say that you probably never even, many of you never even thought, and I'd like to hear your words in a second, if you even think about the percentage, but that's really important in here as well. They're the two numbers you want to focus. So if you look at this patient has a Cd4 count of 268 and a percentage of 30. Why do I care about that? The most stable number among those two, believe it or not, is the percentage. It's not the absolute. This number we calculate. So if there's any other fluctuation in your blood count, this absolute's going to be off. So that's why when someone calls me and I say, let me go pull it up again, and I look and I see that the last time their percentage was 30, but this maybe now is 210, I say there's no difference because you're really looking at percentage. I know that probably is like, where did that come from? No one has ever told me that, but I just want you to be aware if you've ever called a provider and they say to you, let me look, and they say there really is no difference. So you scratch your head like, how can my CD4 count be 500 3 months ago, and now you're telling me it's 410 and there's really no difference? To me, that's 90 lower. And it's really because two things. You really need a big change for that to happen, and you really need to look at the percentage. I'm going to stop. This is probably the most complicated thing I'm going to talk about, but I want you to understand this part because I feel like I get the most questions from this. Does anybody have any questions on that one?
Yes, hi, Dr. Short. This
There
is
you go.
I
I was going to say, if there are no questions, I did something wrong. There's got to be a question.
No, I have a question. So I know in my history, I got diagnosed in 1987. And then somewhere along the lines, I got an AIDS diagnosis, and I was under I think I was under 250. So what is the standard to say that someone would have clinical AIDS these days? Because that's a number that I'm sure a lot of your patients may ask.
Yep, absolutely. So great question. So, and I'm going to come back to your comment too. So that in general, when you're talking about what constitutes an AIDS diagnosis, it's a CD4 count less than 200 or a percentage less than 14%. So it's one of those two. Now, I tend to not use that word in practice a lot because it really scares people, right? Everyone knows that when you hear that, you get me 87, we know that was a very different time. But what happens is, so say you come in with a CD4 count now of 100, and I see this a lot. Their counts are low, they're very sick. I give them HIV medications, and then they come back and they look like this. And then, so what happens to the AIDS diagnosis? Did that go away? Because now all of a sudden they're above that 200. What happens to the AIDS diagnosis?
It remains.
It remains. But clinically, you're doing well, right? you're gaining weight, you feel great, you look much better, you feel much better. So what I tell you, and if you leave with anything, when we talk about an AIDS diagnosis, that's really used for statistical purposes. And a lot of people dwell on it, and I know it's very hard to hear, oh my God, I have an AIDS diagnosis. I think if you were living in 1987 when AZT first came out, AIDS diagnosis meant, oh my God, what's next? There is nothing, right? It's AZT, and then 1991 DDI got approved. So things were like, scratch your head, what do I do next? These were very bad times. You know, we obviously move forward, and I'm not trying to minimize it. I just tell you that I don't want you to focus on it, because I have patients who've had 0 T cells. I see them every day. I see them once every 6 months. They look, their life is totally normal. They're taking their pill, they feel great. But by statistics, they meet that AIDS diagnosis criteria. And again, not minimizing an AIDS diagnosis, it's really traumatic for people. I totally understand it. But what I tell people is, this is a very different time. That number is going to go up. But by definition, just what you said, Keith, you're going to stay with an AIDS diagnosis.
So Dr. Short, we did have a
Yep.
question in the chat,
Sure.
and it was from Garrett, and he asked, I know we usually take the blood work on an empty stomach. Does eating influence the numbers?
Not CD4. What's going to influence the number is right in here, morning versus night. But again, it's not going to be more than 30%. Where the fasting comes in, I'm going to get to it, is really for 2 things: your blood sugar and your lipids. It's really probably it's an amazing question. If you really want to know before you go in, because I have patients come in and then I realize, oh crap, I didn't tell them I'm going to get this the next day. If someone's coming in just to get CD4 viral load, you know, their kidney, their liver check, you don't need to fast. It's only when you're getting your lipids checked, so that's your cholesterol, your triglycerides, and your fasting blood sugar. They're the things that you need to be fasting for. Other than that, you don't have to fast.
Then
Okay.
how often would you get those tests?
So it depends on so minimum once a year. Right, that's once a year. However, let's just say you have high cholesterol, high triglycerides. I may get them every time you come in. So at a minimum, it's once a year. So if you're seeing a provider every 4 months, every 4 months, every 3 months, every 6 months, I would just say, do I need to be fasted the next time? Because not everyone likes to fast for 12 hours.
Yeah.
Fun. I know I don't. So a very good question. Please keep these questions coming. So.
We're good.
Yeah, go ahead.
Yep, you're good.
Okay, so let's talk about the frequency of monitoring. You know, this is changing dramatically in our field. When you enter into care, you're going to get a Cd4 count checked. Once we get past that initial stage, I want you to all stop and think, what else do you really do with that Cd4 count? You don't do much of anything unless it's under 200 and you want to make sure you got to take your Bactrim, right? Because you don't want to get PCP pneumonia. You want to take this for this. But once you get up into the 300 to 500 range, there's guidelines now. And I got to tell you myself, I'm older. I don't do it all the time. It's very hard. But the recommendation is, believe it or not, if your T cells are between 300 to 500 and you are virally suppressed, you can do that Cd4 count once a year. And if you're greater than 500, I know, don't yell at me, I'm just saying, the recommendation is not to do it, because there's nothing you do with it. The viral load is going to be your most important number. Questions on that? Because I know that's got to bring up some controversy.
It's just the difference.
So you're saying if I don't have to get my virals like 3-4 times a year if I'm between 300 and 500?
Yep, it's the recommendation. Yeah, I tend to do it in someone who's above 500 once a year.
Wow.
Yeah, most of us don't do it though. So don't go back and say Dr. Short said. I do it. It's a very hard habit to break because I do CD4 viral load all the time. But if you think about, and I don't know who's speaking, so I'm just going to say, if you get your CD4 count checked, think back. What has ever been done when your CD4 came back X, Y, or Z, assuming it's above 300 and above 500. You've really never done anything, right?
No.
That's why. It's really about, why are you, and I feel like it causes more anxiety for individuals because it is all over the place. It's not a steady number. It's all over the place. So like I said, you could check it right now. You can come back an hour later. It's going to be different. So that's why the recommendation is you don't have to do it. Go ahead.
I'm sorry, this is Jimmy. Does the season affect your CD4 counts?
Does the what?
The seasons, like spring, summer, fall, winter?
Believe it or not, when I say everything can affect your CD4 count,
Okay.
it absolutely can. How you feel, if you're just waking up, it's going to be higher. If you're at the end of a day, it could be lower. At the end of my presentation, it's probably lower than it was before you started. So it's really all over the place. But what's really important is it significant? And is it significant that most times you're not going to drop from 500 to 100 unless there's something else wrong?
Okay, thank you.
Yeah, no, great question. The other thing is, if you've looked at your labs and you see all this mess here, it's actually recommended you not do all that. You really only need, we used to look at what's your CD8 count, what's the ratio? Oh, now it's above 1. When you first got acquired HIV, your CD4 was going down, your CD8 was going up. We don't use any of that anymore. So they actually recommend not getting this extensive panel.
So I have a question for you.
Of course.
This is Keith Carter again. So what do you do with your patients that are on like Ryan White or the SBPP and they have to provide that information twice a year? Will you obviously give them the?
Absolutely. No, I get it. Yeah, absolutely. So if you need it for whatever you need it for, absolutely we'll get it. 100%. Yeah, I would never not do it if somebody needed to get SBBP certified for sure.
So what do you do with your patients? I'm William Carter. So what do you do with that patient who drops below 200? How do you get them to go back to adhering to taking their regimen and to show them, because there's a lot of underlying circumstances, but just getting them emotionally prepared,
absolutely,
either way to do that, because then it runs into 9 million other questions on how to get them. Because if they aren't mentally there, how do you help them help you?
Yep. So when I have anyone who comes to me who's off meds, one is, I think having the rapport, first of all, with someone is critical. So, that initial slide I showed was just, a graph, but having a rapport with someone who is not afraid to come in and say, listen, I just couldn't do it. I had to stop. And I feel like I have that rapport with the majority of my patients, not all, but the majority will tell me, listen, I just stopped it. Because one, you don't want to be judged, right? There's some reason that you stopped this medication. We know that taking HIV medication is really important for a lot of reasons. But like you said, today something tragic happened. Somebody died, they had COVID. I mean, whatever the circumstances is, you're just over the whole system. You had a bad experience in a healthcare setting and you're done with the whole situation. And that stuff happens. But it's really about, how can I talk to you? Is it you don't want to take them anymore? Do you want to go back on them? What can we do to support you? Do you need counseling? Do you need this? And then again, I do a lot of explaining about, having your CD4 count drop below a certain number and what things that put you at risk for. I think most people think when their counts drop, you're going to get an infection, you're going to get PCP pneumonia or something weird. What I think is not really readily known, and I may be preaching to the choir because you guys may know this, is that one of the things that came out of the trial that really said we need to start taking medications right at diagnosis was there were what we call non-AIDS conditions. So there's a lot of cancers, there's heart disease, there's liver disease, there's kidney disease. That all came and was seen more frequently in people who are off their HIV medications. So I do a lot of that explaining and then try to see what we can do to assist to get him or her back on their HIV medication. Did that help?
That helped me, but I'm sorry, but it just brought up one more question to me. I see a lot lately people are, you know, taking their meds maybe 1 month and then going back on them or going off of them for a half a year doing that. I don't understand how they're doing that. And when they come in, when they get their labs, I know that's shown that they aren't taking it because, you know, their numbers show it. But how, you know, but they are like readily telling others, but they aren't telling their providers. And the providers, from what I've been told, you know, by these people who say it, that they don't mention it either.
Right. So, I mean, I look for little clues. So if I hadn't seen someone in a year and a half, I don't care if their last CD4 was 500. I'm going to get everything because I don't know what happened in a year and a half, right? I mean, we have excellent retention abilities in our clinic that will reach out to people who've been out of care, get them in care. And, you know, it's really about trying to figure out why. I think one thing we've seen during the COVID pandemic is, you know, so many things got in the way of taking antiretrovirals. You know, I had someone who I just saw who literally said to me, "I'm sorry, doc, I've been off for a year and a half. I just couldn't do it. Too stressed out." You know what? And I said to him, "Do you want to go back on?" And he just needed me to say, "I think you should." And he went right back on. And I followed up the next day with a call and he went back on. So no, I agree. I mean, but someone out of care like that, I would get a full set of numbers to see where there are. And I'm not going to say I don't see patients where they take to me, "No, I never miss a dose." And then I get a 12,000 viral load. They've always been suppressed. And then I call and I say, how many doses have you missed? Your viral is 12,000. "I'm sorry, I've been off for about a month." And they don't want to tell me in person because they know they're going to disappoint me. And we have a conversation and they get back on their medication. And let's just say they were someone I saw every 3 months. I'd say, "I want to see you in about 3 weeks to make sure you're going down." That's my approach to it. Every provider is different. That's my approach.
So
I actually have a question. Sorry. Something I've noticed, my name is Liam. I'm a
Hello.
medical case manager. And one of my questions, which I've kind of noticed with some of my clients is, you know, they do have sometimes difficulty like remembering to take their medication. So they'll try to switch it, like say from breakfast to dinner, or they change it around and they continuously change it when they're supposed to. How does that affect, like, I guess, their lab work in the end? Like, will it affect it drastically or?
Sure. So it's a good question. I think it depends on the drug. That's the, I guess, good point and the bad point of what we have now available. It's with 38 different agents. It really depends on the drug. For the most part, what people are using nowadays, regimens that are sort of the standard, unless you're on a very, very old D4T, 3TC, Crixivan. It's on that. I know some people probably said, "Wow, I remember that regimen."
I remember that regimen.
Those drugs were very, very, very critical of time periods. So if you were on Crixivan or Indinavir, that was 800 milligrams, 2 tablets. I remember this off the top of my head, and it's been so long, every 8 hours, like clockwork. And what happened is if you messed around with those times on an empty stomach, bless you, with a full glass of water, your levels would dip below the required thing. Very different now. The levels of drugs are so much better than where they were. So what I say with switching back is, obviously it's what works for the patient. You know, does the drug need to be taken with food or an empty stomach? And then I usually tell people, make sure you just try to stick with one, but you're allowed to, you know, move it around. So, you know, for example, if today I'm taking a drug every day at 9 a.m., but I want to start doing the 6 p.m., I just move it forward. That little 6-hour window is not going to really impact. And that really should not come into play with any of the labs that I'm really talking about. Hopefully.
So we do have a question that's been sitting here in the chat that I
Yep.
want to go over. And the question is,
And I want to thank you. This is just what I wanted. More questions and less slides.
doesn't the CD8 count also help to decide how often to check CD4s? Given that a high CD8 count suggests that your immune system is more primed to respond more quickly at need.
Right. So I'm going to turn the question around and think of it this way. What if your well, first of all, if your CD4 count was low, your CD8 count would be high, because remember, they're reversed. So if your CD4 count was low, we would never stop checking your labs. we would keep going. It's when you're into that 300 to 500 range, you sort of get that balance and move the ratio closer to 1. But let's just say your CD4 count was still a little higher than your thing. There's nothing you would do to change that ratio except continue to take your meds to build your CD4 count up. Hopefully that makes sense. So there's nothing out there that we could target to increase your CD8 cells. It's the same question for what if someone, and I hate to say older because I'm 56, but as you get older, if someone gets diagnosed and they're 55, 56 years old, say they present with a CD4 count of 50. You give them HIV medications, they get up, they hit 120 CD4 cells, and they will not budge above that, right? They stay there. There's not much you can do for that. A lot of times people used to switch medication, that does nothing. People used to give hormones, interleukin-2, that does nothing. Really, the answer is you just keep them going and keep that viral load suppressed. That's really why all this data came out about when and how to monitor. So again, just if you stick within this 300 to 500 range, your CD8 ratio should not be higher than your CD4 count. Hopefully that answered.
Okay, we have another question from the chat that was sitting here, and I'm sorry, I apologize for missing this. If a person consistently stays at about 290, I've been positive since 1987. Should there be additional testing?
So that's the, I don't know how old this person is that I asked, but that's just the case I was talking about. You're sort of stuck in that window where you're not going to get much of the question you have to ask is your viral load suppressed? If your viral load suppressed and you're stuck at 290, we do nothing different. It's really the viral load we're looking at. Can't really do anything to get that CD4 count above. It's just really time.
This is Jay.
Someone was very kind enough to address the issue about SBBP, so everybody's clear on this. That has the same correct information. SBBP, PB, I can't say it with my teeth, excuse me, does not require for you to submit labs after the initial enrollment. I just re-enrolled, there was a re-enrollment of someone, and SBBP are also transitioning to certify people for a year instead of 6 months. That is in fact correct, yes.
Yep. Did we get all the questions in the box?
Let's see. So there's a question. Sometimes I forget if I took my meds, do I end up taking it and maybe taking it twice or skip it that night?
Here's a good way to remember it. I'm assuming this is a once a day medication. Twice a day is a little different. Think about, I'm going to use these numbers just so you can have a frame. So if you are taking your HIV medication at 9 a.m., always think about 9 p.m. So 12 hours. So you have 24 hours in a day, go 12 hours forward. Excuse me. If you realize, oh crap, I forgot my medication and it's 11 a.m., 12 a.m., 1 p.m., 2 p.m., 3 p.m., 4 p.m., then you would take it then and then repeat tomorrow morning at 9 a.m. So if it's within that 12 hours, you want to take it, 12-hour window. And I'm using the 9 to 9. So 9 a.m. you normally take it. If you realize anytime before 9 p.m., take it then, and then get back on your schedule the next day at 9 a.m. If it's after, so say you remember, oh crap, it's 11 p.m., I forgot to take it from 9, you want to skip that and then do it 9 a.m. So it's sort of a 12-hour. And the main reason is you don't want to double up on certain drugs, especially where there's kidney potential for kidney toxicity. That's really the reason. You don't want to double those drugs up. So in a general way to think about it is whatever time you normally take it, move forward and make that the PM. So 8 a.m., 8 p.m., 7 p.m., 7, whatever. After that, you want to skip till the next day.
So there's someone that provided a suggestion that they use. They said, I find that by using pill boxes that have a week's meds set out in advance, I can see if I've taken or missed my med dose for that time of day. That's a great idea.
Yep. But things do come up, right? I mean, there's always, one thing I find is I give patients a little key holder and it's a little, I don't know, I call it a little tiny flat. and it's enough for one pill. Put it on their keychain. If you know you're going to be out, stick the pill in there in case. That way you're not, a lot of people put it in their pocket, but you could have it on there as well. Great questions. All right.
I
go
think
ahead.
that was all the questions so far thus far in the chat. So if you want to move on to your next segment.
Yep, I'm going to do viral load. This is maybe going to blow your mind a little bit because this draws a lot of confusion. So everyone knows what a viral load is. It's how much virus you have in your blood. We measure it by this thing called PCR. So if you see HIV RNA by PCR, that's really what it is. This is the technology that we use. So everything, when we order a lab, there's a limit. What's the lower limit? What's the upper limit? The lower limit is usually less than 20. The higher limit is more than 10 million, right? So lower limit we know, and we call that undetectable. But there's a but there. The true definition of undetectable is less than 200, right? And we call a blip is when your viral load's greater than 50 or greater than 20, but less than 200. That's not viral failure. I'm going to repeat that again. So let's say you're going along and every day you get your labs back and your viral load's less than 20, less than 20. All of a sudden, oh my God, my viral load is 80. And everyone panics. Typically, if you are first of all, you truly are undetectable. We have become so used to saying that less than 20 is undetectable. And that's why we do it. But that's the assay. The true definition is less than 200. The big question everyone has and is important is, I don't want to transmit to my partner who does not have HIV. The viral load that was used in all those trials was less than 200. So you're not going to transmit if your viral load is less than 200. I know there's got to be questions in there, so I'm going to stop and take some right.
If you want to unmute yourself, you can ask the question directly, but thus far I do not see anything in the chat. So does anyone have a question they would like to ask the Dr. Short directly? Don't be shy.
All right, I'll move forward then.
I have one question.
There you go.
Do you, as a practitioner, for those of us who have partners who may be undetectable, do you, I know my practitioner, he asked me to bring my partner in. And I, when I'm out advocating, I just came off a clinical trial. I refuse to answer any of my partner's questions. If you want to know about it, I've told you what I'm doing and why we aren't doing. You need to come in. So how do you ask your patients how to be a good patient? There are plenty of nice patients, but how to be a good patient so that way you're able to, give them the best treatment possible.
Yeah, no, I mean, I always ask, because I'm willing to explain all this stuff, I see so many patients and each patient is unique. Some patients have a partner that's also positive. Some people have a partner that's negative and they're very comfortable with understanding U equals U. I have some who are comfortable, but they want to be on PrEP. And then I have some who are totally uncomfortable and they don't. So in any of the cases, I always say, feel free to come into the practice. I will also say within when I see patients for PrEP, so these are patients who do not have HIV, they're actually using medication for prevention, not treatment. They always, and if they have a partner that's positive, I always say, especially because they're out of the system, feel free to bring your partner in because that what they do, and I say, make sure they bring their labs. So that's really helpful there is when you can get them on the same page and outline their labs and say, look, he's had an undetectable viral load for this amount of time. There really is no chance that you can get HIV unless he stops his medication. And I really make that point, here it just shows you that he is undetectable. He has been undetectable for X amount of time. So I always encourage people to bring anybody in, families, and I like it, but I understand when people say, nobody knows, I'm not disclosing anything. So I don't push it. I talk to them, have a conversation and say, anytime you want to bring someone, I'm happy to disclose, talk. if you want to bring them in to we can disclose, if you want to bring them in to have a discussion, if you want to talk about your meds, a lot of times where I'm not insistent when I have patients who I worry about that are not taking medications or getting sicker. I always say, is there a support person? And I really try to get that person in to say, please help me. This person's seeing me maybe once every 2 weeks because they're so sick, but they're with you every day at home. Please help this person remember to take their medication. Please help them do this. I don't want them to get sick. I don't want them to die. And I found that to be helpful. So yeah, I do whatever the patient will want me to do for sure. Great questions. All right, we are going to switch to sugar. So everyone talks about blood sugar. The name for it that you'll see in your labs is glucose. And glucose sort of hangs out on what we call a basic metabolic panel or a comprehensive metabolic panel. Glucose in simple form basically provides energy. And then there's multiple different versions of it. Glucose gets converted to glycogen stored in your liver. So if you're exercising, you use up the glucose, you need other sources of this glycogen stored in your liver. It's broken down to glucose. The problem comes in, and I didn't talk about low glucose. I'm going to focus really on diabetes. So high blood glucose is what we call diabetes. I listed down here a whole host of risk factors for diabetes. So one, getting older, having an inactive lifestyle. If you already have high blood pressure, for those who could potentially get pregnant, this is just your sugar is not doing what it needs to do. If you have high cholesterol, if your body mass index, which means you're overweight, and then if you have a family history. So these are all the things, and I will throw in here that there are in the field of HIV, we're seeing a swing where it used to be a lot of patients had weight loss. We're seeing more the opposite. We see a lot of weight gain. And with weight gain comes all these things here. You get impaired glucose tolerance. Your glucose and insulin are just not working right. High blood pressure, and then you lead to diabetes. So there's different types of sugar tests. I'm going to go through this slide and the next and then open it up. So there's different types of glucose tests, and I listed them all here. Most of them, the first, second, and the fourth, they're things that are probably done in your office. One is just a random blood sugar. So that means you come in, you're not fasting, I check your blood sugar. So maybe you just had something to eat. Maybe you just had, like in my case, Pepsi, which is my addiction. I have a whole bottle of Pepsi. So that's a random. I'm not fasting at all. You want to see what your sugar is. Really what you want to have is this fasting glucose. And I mentioned this in the beginning. Excuse me, when you're asking your provider, do I need to be fasting? One of the things we look at is the sugar. And that's nothing to eat or drink except for water for 8 hours prior. And I'll tell you why we look at fasting. And then the hemoglobin A1C actually looks at your glucose over 3 months. So a good way to think about this is, and I always call this is the secret way. This is the one you can fix. So if you know, I have an appointment in a week, you fix your diet. Maybe you don't have whatever you're doing, maybe your snacks, your Hershey bar, your whatever, all the things that you typically think of. You come in and you get your sugar done and it's 80. It looks great. This doesn't give you that ability. Your hemoglobin A1C actually measures your glucose over 3 months because the sugar, binds to your red blood cells, and that's what's actually measured. And it's given as a percentage. This other test here, a lot of people just don't do anymore. It's usually done during pregnancy. I can't see, I'm sure there. So if you've been pregnant, you will know that you have at 27 weeks of pregnancy, you drink a sugary drink and then you get your sugar checked. You can have a 1 or a 3 hour, they call them glucolas. So these are the different types of sugars. So how do I know if I have diabetes? So there's really 3 ways. The third way is doing this, but really most of what's done in clinical practice are these 2 right here. So coming in with a fasting blood sugar of 126 or higher, and it's got to be on 2 occasions. If you have a fasting sugar of 100 to 125, that's what we call pre-diabetes. Come back to that too. and then having an A1C that's greater than 6.5%. So these are routine labs done. I will say that if you have this sugar and you get your fasting sugar that's 123, you're pre-diabetic. That's a warning sign to you. Like, I got to do something. I got to cut down on my sugar. I got to start exercising. I got to lose weight. Whatever it is you need to do to help fix this number to get it below 100. All right. Questions on the sugar. Again, this is very important because we're seeing a lot more patients with diabetes. And again, that's sort of following as we get older and our weight's getting more, we're gaining more and more weight, it puts you at risk for diabetes. So
this is James. I have a question.
There we go. I knew something was going to trigger all these guys. Go ahead, shoot.
Sorry.
No, please.
Can HIV meds trigger diabetes, or is that the old meds?
Great question. So this may open a can of worms. So yes, so Crixivan and the protease inhibitors were very, very commonly associated with diabetes. They actually looked at mechanisms and they would actually work against your glucose. So absolutely correct. Where we are now, though, is in the era of integrase inhibitors. Dolutegravir, bictegravir, plus the new form of tenofovir. We know that those drugs are associated with weight gain, and we're starting to see, it's still early, and I don't want to scare anyone. Patients who are on that and gaining weight, remember, think of it as there can be family history, but really it's a lot about getting older and gaining weight. And as you gain more and more weight, your body becomes resistant to, remember, insulin brings your sugar down. Your body becomes resistant to that, and that's what triggers this. So the big question is, do integrase inhibitors, raltegravir, dolutegravir, bictegravir, Biktarvy, Icentris, those classes of drug actually lead to this? And that's still a really unanswered question. There are associations with that. So short answer is maybe. We're coming to that, though.
Okay, thank you.
It's really about monitoring your weight.
Another question in the chat.
Yep.
For fasting blood draws at the first thing in the morning appointment, is it okay? Or to take meds at the normal morning time, when that is before the fasting blood draw?
So yes, great question. So I would say, depending on the medication, so let's just say you're taking Complera or Defci. We know that you need to take that with food, right? What I would say is get your blood drawn and then take your meds, because you don't want to take it on an empty stomach if you require food. So anything that requires food, I would say hold on to. But if you take it on an empty stomach, absolutely go ahead and take it with water, not juice, because again, juice is going to affect it because it's simple sugars and they're going to raise your blood glucose up. Great question.
You have a raised hand from Kevin.
Yes, I have a question.
Hello.
Okay.
I'm the opposite. My family has a history of diabetes, but my diabetes and blood pressure is very low. And I take my meds religiously every morning, but sometimes I feel so lightheaded. I try to drink, sodas and whatever I can before I go into see my doctor. I don't know exactly why I'm so tired all the time.
And you are 70. How old are you again? Yeah,
I'm not 70. I am 65 years old, okay? Let's not push it. But
I mean, again, they're complicated answers without knowing your history. But I mean, I think if you're feeling fatigue, one thing you want to say is, what is your fasting sugar, right? Is your fasting sugar falling below a certain number where you would feel dizzy? If you're waking up and your fasting sugar is 50 or 55, maybe that's not good. So you may need a tweak of your medication. So that's something I would look at. And maybe your A1C is going down into the 4s or 5. So again, something you need to discuss with your provider, especially if you're feeling dizzy.
So I'd like to piggyback on that. What about maybe, do you think maybe the testosterone levels are low? Could that also be causing the fatigue?
Absolutely. Yep. Always check testosterone. Just make sure before you start testosterone, you get your prostate checked.
So what would women check, let's say, with that? Like,
Say it one
you
more
know,
time.
that testosterone is a man-related question. What should women check if they're feeling fatigued?
I mean, we don't test testosterone in women, but again, all the things you talk about, you would get. What I would do if someone came to see me, I would check all routine labs, make sure there's nothing wrong there. And, you know, sometimes the numbers can be deceiving. So maybe it's the sugar is low when you screen, but it rises after they eat something. So then maybe you need something like an A1C. And then, you know, what other factors are going on? You know, is their heart okay? Is their lungs? You know, do they have a liver problem? Do they have this? I mean, you know, do they, especially now, you know, are people feeling down because of what's going on with COVID? So there's a lot of other factors that come in when someone comes into me and say they don't feel well and feeling fatigued.
So because women's hormone levels fluctuate a lot, you know, they become postmenopausal and all that stuff. How do meds affect them in any way? And what tests can they take to help maybe ease that burden of you know, going through cycle changes from you know, when they're birth born to youth to teenage years? I mean, women are constantly going through change, much more than men, I would imagine.
So we don't really check hormone levels. It's more about controlling those perimenopausal symptoms. And there's excellent things out there to do it. Believe it or not, something as simple as, you know, you may not want to go on estrogen replacement, but you may want to go on something simple like Lexapro. So believe it or not, the SSRIs, what we call, that's your Lexapro, Celexa, drugs we use to treat depression, they're excellent in controlling some perimenopausal symptoms seen. Yeah, a lot of people don't know that, and they're really, really good at that. You know, because you may not want to run the risk of taking excess estrogen and run the risk that you may get breast cancer or something. So yeah, you can use antidepressants.
Dr. Short, I have a question for
Yeah,
you.
of course.
I have had I will find out in 2 weeks that I how my A1Cs for the past year. My A1C has been running in the normal range. My sugar, COVID has not really affected me. I've maintained my weight throughout the whole entire time. But when will he, do you think that he may take me completely off of my medicine? I'm on a low dosage as is, but when do you think that he will take that off?
Low dose of what?
I take
Metformin.
I take a low dosage once a day.
A lot of times,
because it fluctuated for a while. I went off of it for like 4 years. I had bariatric surgery 6 years ago, so I was off of it for quite a while. And then I was surprised he put me on, you know, back on for a little bit. And I don't really want to take it, but I take it because I enjoy living. But I know the complications that come with it being an amputee because of diabetes. I'm petrified of it, but I also do not want to be on it. So I really watch what I literally haven't gained any weight at all. I've been the same weight for 2 years now.
Well, this is Keith talking. I think maybe you, I would also suggest you have an in-depth conversation with your provider, and then you have to look at, do you want to continue to lose limbs if you don't take the metformin? Like, are you willing to lose body parts because you just don't feel like taking your medication?
Oh no, I'm very coherent. No, I enjoy living, and I'm already an amputee, but due from the effects from that, I wasn't, when I had my leg amputated, I wasn't a diabetic, but early on with diabetes, as most people know, they because it doesn't bother them right away. So I lost my legs due to the effects from it. I'm quite healthy. I'm active. I do, you know, most people don't even know that I wear a prosthetic leg, you know, but I'm very coherent because I do enjoy living.
I think it's an important conversation to have.
So, Dr. Short, I have a question for you.
Yep.
They're basically like, because we have an aging portion of this. there are like about 9 chronic diseases that are associated with aging, like high cholesterol, high blood pressure, heart attack, diabetes, kidney disease, depression and anxiety, bone loss and cancer. And there's one other I can't do my own writing. But so what comes first? Do the meds cause these chronic diseases, or do the chronic diseases exacerbate things from the meds, make it worse for us?
Yeah, they're great questions, and honestly, there's no answers. There's no great answers. I think we think the meds contribute. We also think having HIV contributes. I think the best thing that we really look at is going off meds is much worse. I think that's the best way, at least when you look at things. Because again, not everybody wants medications, and the question is, I say when we have definitely studied people who are off their medications. We know what that does, and so the question is, when it's a balancing act of risk and benefit, and really being on the medication. But again, any medication you take for long term can do long-term damage. Again, these labs are important, and I'm going to talk in a second about kidney function, and why your kidneys are targets for some of the drugs we have. We all know about tenofovir, Truvada. And I hear people all the time, they come in and say, oh my God, there's a lawsuit going on. My kidneys are damaged. And I'm like, no. And if your provider is monitoring the things that they need to monitor, you would pick that up. And these things are picked up on these simple blood tests. So while you see all these blood tests and, we say everything's normal, each one of them signifies something different for me. And I'll segue that, and then hopefully that will answer your question. So perfect is the kidneys, and here are the kidneys here, right? These two little bean-shaped guys in your posterior, the back part of your abdomen. They do great jobs. They function, they clear out things, they get all the waste out of your body. And when I look, there are really a couple things I look at. So one is a marker called your serum creatinine. That's in every basic metabolic panel, every comprehensive metabolic panel. This is the most direct sign that your kidney function is abnormal. It can rise. When that starts rising, that's when there's some problems. It's a waste product, and really only the kidney works in it. So that's why this is one of the best. I will say, when we send urine, and I always tell patients, because I find out without me telling them, some people are afraid I'm going to go looking for something. Tell them I'm looking to monitor your kidney. And they laugh at me, and they're like, I know. I'm like, I've never seen anybody that can never pee every time they come to see the office. Usually people are nervous, so they want to go. But that urinalysis is so important. Why? Because this serum number that you get in your blood, this is one of the last things to change. Really what happens first is I start noticing that your kidneys are secreting protein. They're putting out sugar, maybe white blood cells. So the urinalysis really is an in-depth view of what's going on in these kidneys. And then from these numbers, we also calculate what we call as an estimated GFR. This tells how well your kidneys are working. And that's important because some of the drugs you use need to be adjusted. So maybe a provider said, hey, I want you to take this drug every 48 hours, not every day. And that's because maybe your kidney function was declining. So really, the kidneys are really, really important for you. Some of the HIV medications over time can cause damage, and that's why these things are measured. So when I see someone who's on one of the HIV drugs, I get basic metabolic that's going to give me this. I get a urine. And when I'm looking at the urine, I'm looking, are they secreting protein? The kidneys have very tight tubules in them. It's like a hose, right? You turn the hose on from the faucet, you have it plugged in, and it runs through to the other end. There's no leaking in between that, right? It just keeps going. What if there are little holes in there? Things start seeping out. That's what happens with damage to the kidney. But normally it should not be that. And then that damage that leaks out, you pick up in the urine. So that's why we do that urinalysis. They're really important markers for us.
Does anybody have any questions for Dr. Short on?
There's a question.
It
says, if and when an HIV med is suspected of contributing to a problem, do you recommend that your patient consider switching the regimen without? Yes, absolutely. So if there is something that is going on with the medication, either you feel or your provider feels there's absolutely a time to consider change. Totally agree. Absolutely, 100%.
Any questions, anyone? Next slide.
Yep, the liver. So the liver is, there's a couple different tests. The liver tests are a little tricky because we say liver function, right? But really they're different pieces to it. So AST, ALT are enzymes. These are not really function. They're actually included in the cells. When you have high levels of these two, it means there's some type of damage. One, is it medication induced? Does this patient have hepatitis? And then we gave HIV drugs on top of that, and it raises these levels. Is it from alcohol? Is it from different drugs, either prescription, over the counter, or actually you're taking that's not prescribed? So they cause levels of this to go up. You know, one of the common things we're seeing now, and here's your liver here, it's a nice pink liver, is that as you're gaining weight, you know, people start gaining weight and you start getting these bellies that are larger, you're starting to accumulate fat in this liver here, and that's raising these levels here. The more specific number is the ALT, but they both go up in terms of liver damage. And that may be the only marker. If your ALT is rising, and I've checked, there's no medication I think's doing it. You're saying you're not drinking alcohol. There's nothing else. You don't have hepatitis. I will order an ultrasound. I just did it on a patient the other day. He had really abnormal. This was, normally it should be around 20, 30. His was in the hundreds. I checked him, no hepatitis. I went through his med list. He's not drinking alcohol. Occasionally on the weekend, I'm like, that shouldn't do it. I did an ultrasound and his liver was full of fat.
Oh my goodness.
Now I've sent him off to work on getting that under control, because fat in the liver long-term can actually cause cirrhosis. We typically don't think of it. Everyone thinks of cirrhosis as, oh, it's from drinking, it's from hepatitis. It's also from fatty liver.
How do you get rid of the fat in your liver then?
Say it one more time.
How would one get rid of the fat that you're describing from your liver then?
Yep. So there's,
I'm one of those cirrhosis people, hepatitis. I was like the STD sponge, so I had everything.
yeah, no, we used to have nothing. Now we have a couple different things to, well, first of all, losing about 5% of your weight actually helps to decrease the fat content. If your lipids are high, lowering them. And the other way is now we have some drugs, either in the form of injections or in pills. Some people may have heard of, I give you the different names, semaglutide, Ozempic, all those drugs. You can give an injection once a week. Absolutely helps to reduce fat in your liver as well. So, and it's now
that's better than ribavirin and interleukin-2.
Yeah, exactly. Am I right?
Yeah.
God forbid. So these are all numbers. The other one is the bilirubin. So this is, believe it or not, a yellow fluid that's produced when red blood cells break down. Believe it or not, back in the old days, indinavir or crixivan and atazanavir or Rayataz actually caused these numbers to go up. And your eyes would look yellow, right? And it was all because it raised the levels of this. But these are all markers that something's wrong with your liver. So when I order these tests, each one of them tells me a different thing. This tells me there's damage to the cells. Something's going on. Are you drinking? Do you have fat in there? Bilirubin says to me, maybe the medication's doing it. Maybe there's an obstruction. And the same thing with alkaline phosphatase. Is there a blockage in your tubules? And based on that is where I go with my next step.
So you get a hardening score for your patients with liver issues?
Yeah, we get all types of scores. We do fiber scans and yep, absolutely. BIB4, yeah, we do all those things.
Could you just like describe that for some folks that may not be familiar with that? Like
For which one?
If you have cirrhosis, like what are the issues? What tests should you do to monitor your cirrhosis?
Yep. So say you have your liver here, and so in general, what cirrhosis means is that your liver is scarred. And normally, remember, your liver you can't live without a liver. You can live without kidneys, you can't live without a liver. Your liver is very important. So when you have scarring in your liver, you start losing function. So believe it or not, these levels actually go all the way down because you've lost a lot of your cells there. It's like when you get cut in your arm, right? When you get cut in your arm, how does it heal? It forms a scar and then closes up. Well, that happens with any damage to the liver. And over time, that scarring, depending on how much of the surface of the liver it takes over, can actually cause some damage. So what do we do to help preserve that? One is don't drink. Anything you could do to cause damage, do not drink. If you're taking something as simple as Tylenol, don't take more than 4 extra strength tablets in a day, because the liver is what metabolizes this. And if you start going higher, you could damage your liver even more. The other thing we can do is you want to make sure if you have cirrhosis that you get screened every 6 months with an ultrasound to make sure you don't develop cancer. We know that cancer develops in the setting of cirrhosis. It's called hepatocellular carcinoma. So we know that by screening every 6 months, we can do that. And then there are other things you want to get scopes to look at. There's different things that can happen to blood vessels we call varices. So I always say that if you have cirrhosis, you should be in care with a liver doctor, a hepatologist, to make sure that you're getting really the standard of care.
Does anybody have any additional questions regarding your liver and your liver functions?
They're waiting for the STIs. This is getting boring now. We're waiting to talk
And all
sex.
those
James,
two,
This is James, I have a question.
Hey,
I was diagnosed with hepatitis 40 years ago. And my doctor would do periodic liver tests years later. And one came back and said that I had never had the hepatitis, which we all know I did. He doesn't know whether there was a lab mistake or something, but they couldn't detect, I don't know if it's the antibodies or whatever for it.
Yep.
And I just found that really, really odd. That it looked like I never had it, which I did, and we all know I had it. I don't know how to explain that.
yeah, no, I always say if something doesn't make sense, I always repeat it, right? Because remember, there are lab errors. There are definitely lab errors. So no, if you know you had it, you had antibodies in the past, you had the virus in your, I actually, I would repeat the test. That's what I would do.
Okay, thank you.
And especially if you're, you're cleared of it now. Yeah, one thing that I think is an important, good thing to remember, if something does not seem right, and I'm not saying that it happens all the time, but when I teach residents, I always say, you order a test, right? So you walk in and you say, I want you to draw a liver function test. And then you walk away. So you don't know who the person is. They're drawing the test, how they're doing it, who they're doing to. And then it's got to go into a bin. It's got to be labeled. It's then got to be picked up, taken to a lab where thousands of others. So I always say there's so much room for error in that path, right? There's so much room for error. So if something's not sounding right, repeat it. And a lot of times you're going to get your answer that you originally thought of.
Thank you.
Just something to think about.
This is Keith on the hepatitis issue. Even though I've been virally cleared of hepatitis C,
Yep.
I can still get reinfected with hepatitis C.
Absolutely.
And there's a whole list of other forms of hepatitis that we don't even talk about. So it's mainly just A, B, and C. So once you test, you can have hepatitis A, which I've had. Is there anything I can do to prevent, like, I guess, an internal outbreak of it again?
For which one?
For hepatitis A and B, am I protected from it then? Since I was exposed, or?
Yep. So for hepatitis A and B, there's a way you can check to make sure you're protected. You measure antibodies, which are your levels of protection. If they're both negative, we have vaccines for both. Absolutely, you can get vaccinated. And that's really a standard of care if someone has hepatitis C. You want to make sure you're protected against A and B, because something as simple as Hep A, which may just, somebody gets nausea, vomiting, which is what it can be. If you have Hep C and you get Hep A, you can actually cause your liver to fail. So it's really recommended that anyone who has hepatitis C actually have protection and immunizations against A and B.
Okay, so we do have a question in the chat. Oh, I'm sorry.
Yep. No, go ahead.
We have a question in the chat. Can you go over the 3 types of hepatitis? I assume A, B, and C, and that we can clear A and C. Please B, it says then B incorporated itself into the nucleus of the it's something-
Hepatocyte.
Yeah,
Let me open it up. Yep. All right. So there's 3 types of there's actually many more, but
yes.
they give you A, B, C, D. So yes, you can clear A and C. So A, you can, well, let's do one by one. So hepatitis A, majority of the times, 90-some%, you get it, it goes away. It resolves on its own. You never have a problem. It doesn't go on to being chronic. I'm going to come back to B. Hepatitis C, majority of individuals who get hepatitis C, it remains chronic, and then now there's treatments that can cure it. We know that. Hepatitis B is very different. And the difference is Hep B is like HIV in that it gets incorporated into the nucleus, into the host DNA. And once that happens, you can't cure it. Same thing with HIV. The question is, why can we not cure HIV? It's because the DNA of HIV gets incorporated into the nucleus and into the chromosomes of the host. And then some of them sit there and just remain quiet. Same thing with hepatitis B. So that's why we can't cure it, but you can control it. We have HIV medications that control both the HIV and the Hep B. The other one that you should know about is hepatitis D. Hepatitis D you get when you have hepatitis B. It's a co-infection of B. So if anyone's walking around with hepatitis B, you should always ask your provider, do I have evidence of hepatitis D as well?
Then why don't providers just do that test as well? Because, I mean, that would only make sense, wouldn't it?
I think
If
not
there's a
everyone's aware
co-infection-
of D. Not everyone's aware of D, but they should.
Is that covered in medical school?
Quickly, yes, on exams.
So does anybody else have any questions regarding the liver function test or your liver overall?
All right, so we're going to do lipids, and then I believe we're going
Wait, so I have a question. If I go to a physician and I have hepatitis A,
Yep.
then that physician should automatically test me for hepatitis D. That's what you're saying.
So it's Hep B.
It's Hep B. Yeah, Hep B.
It's Hep B.
So
Yeah.
Hep B and Hep D.
Yep. The
if I
B
have-
and D go to B and D go together.
And a provider would automatically know to test for both.
They should. I would ask.
I've never been tested.
Say, have you ever tested me for hepatitis D? It's
Yeah.
rare, but it's also important. You want to know.
I've never been tested for it at all these years. I've never been
Now,
tested.
you wouldn't do it unless you had Hep B. So you wouldn't just do it in general. So when I screen someone who comes in, I do A, B, C. If I know they have B, then I do D. So it's only if you know the person has B.
I've had the whole alphabet.
Thanks.
Yeah, sure, of course.
No, I've I've had many issues. So,
That's all right. All right, we're going to get to the second to the last topic. So lipids. Lipids are really important for us for lots and lots of reasons. So one, fat's a source of energy. We know it's good, and I put the things there that help, raise it. It actually carries some vitamins in your blood. We typically don't think of that. Everyone thinks of fat as bad, but one, it's good for energy. It carries vitamins. It helps make hormones. You talk about testosterone. They're all made from cholesterol, right? A lot of you don't know that. That's what I struggled with in medical school, biochemistry. All that comes from cholesterol and fats. They help make your cell membrane. So without fats, you cannot do all these functions. Fats are wrapped in proteins, and we call them lipoproteins, which I'll show you in a second. We do know that some of the HIV medications we use does raise the level. When you order a lipid panel, I'm going to show you this in the next slide, and then we'll open up for questions. Typically, you get 4 different types of results under a lipid panel. So it's the cholesterol, it's the high density lipoprotein. Remember, this is a lipid plus a protein. You have an LDL and then triglycerides. So let's go through. So cholesterol, we know, is one major thing, but then there's 2 types of it. So this is an overall number. You have what's called the high density lipoprotein, or your good cholesterol, and then the low density lipoprotein, or your bad cholesterol, and then fats. Fats are what, if you eat a cheesesteak and you have all this stuff running around your blood, that's really what triglycerides are. So That's one of the reasons you want to be fasting after you, before you get these labs drawn. You want to make sure you have at least 8 hours. Where the problem is, let me do this one first, is so the LDL, which is your bad cholesterol, basically carries fat from the liver to the rest of your body. And one of the areas is your heart. And so here's an example. Your arteries start getting narrow and then the blood can't flow through there. So that's why you want to know your LDL. And then the good cholesterol does the opposite. It reverses it. So if you look here, you know, the cholesterol goes the other way. So it basically takes it out of the blood, takes it to the liver so you can digest it up. So that's why when I'm looking here, I'm looking at all of these different factors when I look at a lipid panel. You typically want to have a high HDL and a low LDL. And each one of these have targets. The other thing that I think I'll just say real quick is for cholesterol, you want to have this number under 200, and for triglycerides under 150.
There's another question in the chat. Let me get to that. The question is this: are you encouraging your patients to have their vitamin D levels in the upper levels of normal range as a protection against severe COVID disease?
So I do measure vitamin D level, and I do supplement. So yes, I do supplement vitamin D levels. Most people are vitamin D deficient, so I absolutely do.
So do we have any more questions about lipids and that? Let's see. Oh, the good stuff. Yes.
Oh, the good stuff. So I only have 2 slides on this, but again, I want really a discussion here. So I'm only going to talk quickly about 3, because when we start getting into things like herpes, there's a lot of controversies around how to screen. So I want to talk on the 3 that are really, really very important to go through. So syphilis, if any of you are not aware, in Philadelphia, there is a large epidemic of syphilis, and it has really spilled over into cisgender women. So women are seen at an alarming rate. It's 100% increase from the previous year. I see a lot of them at University of Penn. I see them, and they do not have HIV. I've never seen so much syphilis in cisgender women as I'm seeing now. Gonorrhea and chlamydia, I think we all know that. And then hepatitis C is also something that there's many ways to get hep C, but one of them now is through sexual transmission. So these things are really important to do. So how do I'm going to talk about 1 and 3, and then I'm going to do the next slide and talk about gonorrhea and chlamydia. So how do I screen for syphilis? Believe it or not, if someone shows up in my office and they have a rash on their palm and sole, I don't care what the blood test shows, they're going to get a bicillin before they walk out. They will get a blood test for it. So this is typically done through blood testing. And then hepatitis C screening is also done through blood testing. So that's those 2. And then really, how do we screen for gonorrhea and chlamydia? In the old ways, it was give you urine. Well, no, actually in the old ways, it was take that little probe and stick it in the pee-pee hole, as we used to call it, and everyone would jump out of their skin because it was so painful. Now we've improved our technology, and we make you go in the bathroom and give a urine specimen, and it's done through what we call nucleic acid amplification testing. But I will tell you that if you just do urine, you're not doing enough. I'll cover this quickly. So STDs exist in the throat and the rectum as well. We may not think about that, but they do. Men who have sex with men are typically at the highest risk. There's often no symptoms, and that's where I hear all the time is I have no symptoms, but you're calling me and telling me I have gonorrhea in my throat. And it's like, yes, that's what it does. It just sits there with no symptoms. Only detected by screening, and it does increase if you are not HIV positive. It increases your risk of getting HIV. You look here, 1 in 8 had an STD in the throat or the rectum, and a third not screened in the last 12 months. So this is really important, and it's very interesting because if you just screen the urine, you're missing 80+%, believe it or not, of the gonorrhea and chlamydia. So you're missing a ton. How often should you get it done? So if you are sexually active at least once a year, if you're at higher risk, and I'll go through this in a second, it's every 3 to 6 months, and then if indicated, test the throat and the rectum. So I'm going to tell you my approach. So someone comes in, and I have extended this to females as well. I just feel we should, right? I mean, they're focusing on men who have sex with men, but if I have someone who comes in to me, I have an open discussion. You know, when you're having sex, tell me, what are you doing oral sex, anal sex? Are you mutually masturbating? Whatever the things are that you're doing, do you use toys? Do you do that? I ask anything, and they feel free to tell me anything. So then I do a lot of oral sex, right? So I will screen then their throat and rectum. So you say, why their rectum? Remember, what goes through your throat can come out through the bottom. So it can be down there as well. Someone says, I never do anything, I never have any sex, it's all mutual masturbation, then they probably don't need this. But always ask, you know, did someone, and I'm sorry, I'm going to be just as bold as I am with my patients, you have to ask the questions. Does someone put their mouth on your penis? Does someone put their mouth in your vagina, your rectum? All that leads to exposures. And if you have that exposure, it's just about getting screening, because really what you see here are there no symptoms. And you run the risk of having resistance by having gonorrhea living in your throat, and the same thing with rectal. So I know that has to have some discussion and some questions.
Okay, so once you test positive for syphilis,
yep,
you will always get, let's say you get your test today, 6 months from now ago when I did all the treatment and everything, the test is going to come back positive again, isn't it?
It will. So the antibody test.
Right.
Only the antibody test, the titer will change. So you get 2 tests with syphilis. You get a titer. So you'll get a number that says like 1 to 2, 1 to 4, 1 to 1, or negative or non-reactive. That's the number that's going to change, because once you get treatment, that level comes down. Then you're going to get something called treponema pallidum, TPPA, or MHATP. Those stay positive forever. So you're looking at that 1 to 1, 1 to 2. So say you open up your testing and you see syphilis and it says titer 1 to 2. Do you need to panic? The answer is no. You have to ask, what was I before? You know, am I adequately treated? So if you've had syphilis 10 years ago, you got treated, your RPR stays at 1 to 2, nothing to worry about. Where do you worry? If it goes up 4 times. So very easy, you just do the math. It's not really complicated. If you're at 1 to 2, 4 times 2 is 8. 1 to 8 or higher. If you're at 1 to 1, 1 to 4 or higher. But if you're at 1 to 16, 1 to 64 or higher. So all you do is take that second number and multiply it by 4. 4 is what we consider a new infection, or you've been treated and adequately cured, because it works the other way. Say you get testing and you are 1 to 512, you want to see that come down 4-fold. So you want it, then you get your test back at its X number. As long as it's come down by a factor of 4, that means you're cured. So yeah, you're absolutely right. You will continue to test positive for syphilis. Absolutely.
So because STIs are like a gateway to HIV, are you encouraging your patients that may have, they didn't test positive for HIV at the time they came in to go on PrEP?
Yeah, so I don't see patients, well, the only patients that I see who do not have HIV are PrEP patients. So I don't see a general practice of, patients who are mixed. I get referred in someone who's on PrEP. And so what I do is just what it says here. When they come in, I'm asking them, how many partners have you had since your last visit? What are you doing? What activity? And I screen them, oral, urine, and then rectum. I do all of those things because, again, just what you said, that puts you at risk for HIV acquisition. So absolutely. We need to have more of this done in the community. People need to be aware that this needs to be done. Giving someone just a urine cup is not going to get at all of the STDs, STIs that are out there. Most of them are going to be seen in the throat and the rectum.
Do we have any other additional questions, verbal or in the chat? I don't see anything in the chat. So does anybody have a question for Dr. Short? Okay, so